And welcome to our summer series grand rounds. And we are back on the Zoom format for today, and we are very fortunate to have Dr. Rebecca Leary, who is joining us from her office up in Lewiston. She is a member of Maine Medical Partners Diabetes and Endocrinology. She's a graduate of University of Delaware for undergraduate, University of New England for medical school, and then came through our residency program in internal medicine, and then went on to the Leahy Medical Center for her fellowship in diabetes endocrinology. She came back to Maine, fortunately. We knew her as Rebecca Hillier as a resident. She's now Rebecca Hillier Leary. And she joined Maine Medical Partners in the summer of 2020. So she's had a very normal first year in practice, I'm sure, with the pandemic. But so she's going to be talking to us today on the management of inpatient diabetes. We're also going to be joined by Cindy Young, who is a certified diabetes educator with Maine Medical Partners Diabetes and Endo. She does inpatient and outpatient diabetes education with 28 years of experience. So a great person to help us with this always a timely topic and a great topic. So Rebecca, take it away. Thank you.
All right, thank you very much for having me. Morning, everybody. I did want to mention before I got started that I'm happy to have you ask questions in the chat as I go. Between kind of break points, I'll check in the chat to see if there's questions from people and try and answer them along the way. And if not, I'll make sure I get to them after the presentation has been completed. So other than that, I'm going to go ahead and jump right in. So I'll be talking about the management of inpatient diabetes today. And I don't have, let's see, any disclosures. I did want to go over the objectives. So we'll talk a little bit about inpatient glycemic targets, insulin review, including U500 insulin, estimating insulin requirements, both in patients coming into the hospital and then as well as transitioning off an insulin drip. And then some common management situations, including patients who are NPO on tube feeds or TPN, those patients on steroids. We'll go a little bit into continuous glucose monitors and insulin pumps, just so that you're somewhat familiar with them. And then we'll go over the role of the diabetes educators, which Cindy Young will take over for the presentation. And I did just want to mention that most of the things that I'll be talking about today are general approach to inpatient diabetes management and not specific MMC guidelines. So that because this is targeted towards the residents, I did just want to kind of put that in there. So, you know, wherever you end up practicing, hopefully this will be relevant information to you, but it doesn't necessarily align perfectly in all aspects with the Maine Med guidelines. All right, so what are we aiming for? So the glycemic targets in patients inpatient. So it really depends on if they are critically ill or not critically ill. The ADA says that in non-critically ill patients, the goal blood sugar is 140 to 180. I believe Maine Med is 120 to 180. And then the Endocrine Society recommends a pre-prandial blood sugar less than 140 and a random blood glucose less than 180. And then in critically ill patients, the ADA, again, still recommends the same range of 140 to 180, but they specify that they would like you to initiate an insulin drip for persistent hyperglycemia greater than 180. And they do note that in select critically ill patients, you could aim for a more stringent goal of 110 to 140 if this can be achieved without significant hypoglycemia. So that's a big if. And then they also specifically mentioned that the treatment plan should always be reviewed and changed for any blood sugars less than 70 to prevent further hypoglycemia. So why is that? Why do we care about hypoglycemia so much? So there was this study that was published in the New England Journal of Medicine in 2009 called Nice Sugar. And it looked at over 6,000 randomized ICU patients, and they put these patients into one of two groups. One was an intensive glucose control group with a target blood sugar of 81 to 108, and then a conventional glucose control group, which was a target blood glucose less than 180. And what they found was that death from any cause within 90 days was significantly higher in the intensive control group when compared to the conventional control group. The incidence of severe hypoglycemia, which they defined as a blood glucose less than or equal to 40, was significantly higher in the intensive control group. And there was no difference in number of days in the ICU or the hospital. Another study published in Diabetes Care in 2009, which was a retrospective cohort study, looked at over 4,000 admissions and about 2,500 patients on a general floor, and these patients with diabetes. And here they defined hypoglycemia, again, pretty aggressively as a blood glucose less than 50. And they found that this was occurring in 7.7% of admissions, which is higher than I think most of us would expect. And they noted that each additional day with this severe level of hypoglycemia was associated with an 85% increase in risk of inpatient death, and then a 66% increase in risk of death at 1 year. Again, pretty impressive numbers. They also noted in this study that the length of stay did increase by about 2.5 days for each day with hypoglycemia. So again, it's just highlights the importance of avoiding this. And if it does happen, making an immediate adjustment to the regimen to avoid further episodes. All right, so it's not the most interesting slide, I'll tell you that, but it is, I think, one of the most important slides for understanding diabetes management, because if you know the onset, the peak, the duration of the insulins and the different insulins that we prescribe, I think it really you can figure out a lot of the rest of the things that I'm discussing today. So the first that I want to go over is regular U100 insulin, which is one of the first insulins that was on the market. And this has an onset of about 30 minutes, peaks after about 2 to 3 hours, and lasts 6 hours. And then and then shortly after, the Aspart and the Lispro came on the market. And the whole purpose of these insulins are the quicker onset, the 5 to 15 minutes, so they don't have to be timed quite as far in advance of a meal in order for them to be active during a meal. So these start within 5 to 15 minutes, peak within an hour to 2 hours, and have a duration of 3 to 4 hours. Then you have your intermediate acting insulins, which are NPH, which has an onset between 30 and 60 minutes, peaks around 4 to 6 hours, and has a duration of about 8 to 12 hours. And I put regular U500 insulin in here as well, mostly because I think it's important to note that it has a very similar curve to NPH. So when we talk about that a little bit later in the presentation, that's something to remember. And then you have your long-acting insulins, which include Detamir, Glargine, Degludec. There's others, but those are some of the most common. And these really have an onset of 1 to 2 hours, which I like to highlight because these are what we transition patients off of insulin drips onto. And so if you were to, this is where the whole, keep patients on an insulin drip for 1 to 2 hours after you give them basal insulin came from, because the half-life of IV insulin is about 6 minutes, I believe. So it's out of your system pretty quickly when you turn off the drip. And these basal insulins do not start within, after 1 to 2 hours it takes. And then they last usually around 24 hours. Detamir notably sometimes can be a little bit less than that. And then Degludec notably is closer to 42 hours, so a longer acting. And then you have the pre-mixed, and I don't want to spend too much time on these, but I think it's important because you'll oftentimes get patients admitted who are on these in the outpatient setting. And a lot of times people aren't quite sure what to do with it. So it's very straightforward. So Humulin and Novolin 70/30 is essentially just 70% NPH, 30% regular insulin. So if they're on 10 units of this twice a day at home, they're literally just on 7 units of NPH in the morning and the evening, and then 3 units of regular insulin in the morning and the evening. And that's the exact way that you could order it if you wanted to split them up into an intermediate acting and a short acting insulin. And Novolog is just NPH with Aspart, and then Humalog 75/25 is NPH with Lispro. And this is just a graph to kind of discuss these things in a little bit more of a visual way. So again, you have NPH here in the middle, your short acting and rapid acting insulins, and then your longer basal insulins at the bottom. All right, so the type of regimen that we recommend in the hospital is basal bolus insulin. And the whole goal of this is to mimic normal insulin secretion. So, and there's 3 components for it. There's a basal insulin, which is either once daily long acting or twice daily intermediate acting, like an NPH, or and then you have prandial mealtime insulin, and then there's correctional insulin as well. So this graphic from the American Diabetes Association, I think, is a good one to look at. So this darker area in the back is kind of what normal insulin secretion looks like with 3 meals a day. And you can see that you have this background amount of insulin being produced, which we try and mimic with long-acting basal insulin coverage. And I don't know why this line here on this graphic doesn't continue, but ideally it would continue all the way through and start to wean off right around when it was diagnosed or dosed the night before. And then you have your short-acting insulin profile, and really those are usually given with meals to try and mimic that increase in insulin surge right after your blood sugars increase with a meal. All right, and then so why do we like basal bolus insulin regimen? So there was a study published in Diabetes Care in 2007 called the Rabbit-2 trial, and this looked at this exact question. So it was a prospective multi-center randomized trial, and it looked at about 130 insulin naive patients with type 2 diabetes, and they randomized them to receive either a basal bolus regimen or a correctional insulin protocol. And so the patients that were in the basal bolus regimen received glargine once daily, blue lysine, which is a short-acting or rapid-acting insulin before meals. And they also received correctional blue lysine as well for blood sugars anywhere between 200 to 400. And then the correctional only group was given insulin 4 times a day for any blood sugars greater than 140. And this was based on a scale. So the mean admission glucose for these patients was 229, so not excellent control at baseline, and their A1C was 8.8. So I'd say this is pretty similar to a lot of the patients we see at Maine Medical Center. And insulin doses in both groups were titrated according to blood sugars. And basically they found that the blood glucose target of less than 140 was achieved in 66% of the basal bolus group and only 38% in the correctional insulin group. So you just get better blood sugar control. And this is actually a little bit more of an aggressive goal than we have here at Maine Medical Center, but highlights the point. All right, so going into a little more detail of each of these insulins. So basal insulin, we talked about a little bit already. You have your glargine, detamir, degludec, and NPH twice a day, which is an intermediate. The thing to mention about NPH is it does have that peak, if you remember the graph that I showed you a couple slides back. So you want to be somewhat cautious with when it is peaking, which is about 4 to 6 hours after dosing it. So that's middle of the day if you dose it in the morning, and then middle of the night if you dose it before bedtime. And then the longer acting insulins, the glargine, detamir, degludec, need to be more cautious with in renal failure because insulins are cleared through the kidneys, and therefore they can last longer in patients with decreased renal clearance. And then something I'd like to just mention is that if we dose basal insulin correctly, that's a big if, but if we do, it should not cause hypoglycemia when a patient is NPO. Now, that being said, when patients come into the hospital, oftentimes their outpatient doses are not, they're not correct. So in a type 2 diabetic patient who we are trying to avoid mealtime insulin or refuses mealtime insulin, we may go up on their basal insulin a little bit more than we really should for their basal insulin requirements to try and get their blood sugars under better control without actually starting them on a mealtime insulin. So it's a caution, but at the same time, if things are done correctly in the hospital and it's an insulin naive patient, you really should be able to avoid hypoglycemia. Now, prandial insulin. So this is given before or with food, and the whole point of this is to prevent hyperglycemia. And it's at Maine Medical Center based on a carb ratio. And then in certain circumstances, it can be a fixed dose as well. Sometimes we see this with tube feeds or patients who are on TPN and kind of getting continuous nutrition. It works better to just give them a fixed dose every so often. So we already kind of talked about the pharmacokinetics of these insulins, but I guess the point that I wanted to make here is that these rapid actings have better control in patients who are eating because they don't need to be dosed as far in advance. But the benefit of the regular insulin is that it has a longer duration. So if you do have a patient on tube feeds, they don't have to get scheduled injections every 4 hours like they would with Aspart or Lispro. They can do it every 6 hours with regular insulin. So that also helps to save time with our nurses and staff as well. So this type of insulin you want to hold if the patient's NPO. And just a note, if you're not sure how much the patient is going to eat, this isn't an ideal way of doing things, but if you have a patient who came in with nausea, vomiting, and this is their first meal, and they say they're really hungry, but you're kind of a bit skeptical, you can give the short-acting insulin or the prandial insulin 30 to 60 minutes after the meal. So that way you're not giving them the full dose and then finding out later that they only took a couple bites and didn't feel well. Because in that case, they would be at risk for hypoglycemia for the next 4 to 6 hours, depending on what type of insulin they received. So then you have your correctional insulin. So the whole goal of this is to, again, give before a meal, and it's to lower the blood sugar prior to eating. And notably, this is not to treat postprandial hyperglycemia. So the important thing with correctional insulin is that it's always dosed based on a preprandial blood sugar, never a blood sugar right after eating, because you're going to end up giving too much. And one way that we do this correctional insulin is with something called a correction factor. And this is specific to each patient, and it indicates how much you think 1 unit of insulin is going to lower their glucose. So if you were to give them a correction factor of 50, that means you think that 1 unit of insulin will decrease their blood sugar by about 50 points. So this is similar to saying a 1 for every 50 correction scale. So that was a lot. So this is my dog. His name is Frog the dog. He has a giant tongue, and I just kind of wanted to put him in there as like a little bit of a break because there is a lot of information on this. He's pretty cute. Let me see if there's any questions. Nope. Okay. All right. Let's keep going. So a case. So you have a 48-year-old male with a history of type 2 diabetes. At home, he takes Glargine 32 units nightly. Lispro, he knows he takes it, but he can't tell you anything about the dosing. And he takes metformin, and he comes in for pneumonia. His A1C is 9.0. His weight is 110 kilos, and his current blood glucose is 260. And you plan to place the patient on a diabetic diet, and insulin orders need to be entered. And so you are about to try and sort that out. So how do you do this? The first step is to estimate the total daily dose of insulin that you think the patient is going to require. And the best way to start this is determine if you think they have low, intermediate, or very high insulin resistance. And essentially some guidelines that you can use. So low insulin resistant patients tend to be lean, have low outpatient insulin doses. They may be in renal failure. And in this circumstance, you would use their body weight in kilograms times about 0.5 to get their total daily dose of insulin. And then you have patients who you think would be intermediate insulin resistant, and these are your typical type 2 patients. They may be overweight. In this case, you would use their kilograms times 0.6. And then your very insulin resistant patients, morbidly obese, you look at their outpatient regimen and they're on quite hefty doses of insulin. Maybe they're on steroids, which increases insulin resistance, or they have a severe infection or ischemia. And that also, both of those things will also increase the insulin resistance. So in these patients, you may want to start with 0.7 as your ratio here, or your multiplier. So after you have the total daily dose, then you can figure out your basal and your prandial insulin doses. So we like to do this by about 50-50. So about 50% of basal insulin and 50% of prandial insulin is kind of a general rule of thumb. So to figure out the basal dose, you can just divide the total daily dose by 2. And then I usually do reduce it by about 20% just to avoid hypoglycemia, because we know how terrible that is in patient. And then with the prandial insulin dose, if you're using a fixed dose with meals, it's quite straightforward, because again, you're going to use total daily dose divided by 2 for the total daily prandial dose, and then divide that into 3 for their 3 separate meals. But here we use carb ratio. So it's important to know the rule of 500 because that will make it a little bit easier to calculate for you. So if you take 500 divided by the total daily dose, it'll give you an estimated carb ratio to start the patient on. So for example, if you calculate their total daily dose to be 50, it would be about a 1 to 10 units of insulin for every 10 grams of carbs. It would be a good starting point. So correctional insulin, this has a rule as well. We love these in endocrinology. So the most typical rule that you'll see is the 1800 rule, which is going to be for your rapid acting insulins, which is 1800 divided by your total daily dose will give you a correction factor. And remember, as we said before, correction factor would be, if it's 50, then that means you think it's for every 1 unit of insulin, it's going to lower their blood sugar by about 50 points. And again, you can kind of, the other way of doing this, if you don't want to remember the rule of 1800, you can kind of use our insulin order set, and I'll go over that in a minute, but that it essentially has some ways of reminding you about these things. So if they have low insulin sensitivity, it will default to a 1 to every 50 correctional, and should be about a total daily dose of maybe perhaps less than 40 units. The median or standard insulin would be somebody who's getting around a total daily dose of 41 to 80 units, and that is a 1 to every 25 correction. And then you have your high insulin requirement patients who are more resistant, and these patients are getting total daily dose greater than 80 and have the 1 to 16.66 correction factor. So you can do it either way. You can either calculate it or just kind of look at their body habitus and what they're presenting with, and pick this way as well. So this is a screenshot of the main medical center's inpatient insulin order set. And this would be an example of kind of what we talked about when you go. So this is basal insulin up here. We've already discussed this. And then you have your carbohydrate-based prandial and sliding scale correctional insulin. And so you have low, medium, and high dosing and also a custom option as well. So if you're not quite sure or you forget everything we talked about today, you can always fall back on, trying to estimate what you think their insulin requirements are and start with one of these. But if you decide that you want to modify this a little bit, you can either click this custom dosing here, or say you put them in and then you think more about it and you want to adjust what the inputs are, you can modify this order. And what this does is it'll bring up this screen, and down here at the bottom, you have your carb ratio, when to correct over. I would recommend leaving that at 180. And then your correction factors for both mealtime and for bedtime. So say you calculate things to be slightly different. You want a carb ratio of 13 rather than 15. You can just change it right in the order set. This is my cat. Her name is Birdie because we're awful. It's a theme in our house. She's pretty cute too. Any questions? Let's see. What advice do you have for managing diabetes in patients who get put on high dose steroids in patients? That is a great question. And I actually will be going over that in a little bit. So I'll hold on that question for right now. And if you still have questions after we discuss the steroids, please let me know. All right. So those are the starting doses, but the main rule is whatever you pick, if you can back it up and you have a good reason for it, then that's fine. The main thing is looking at what the blood sugars are after you pick your regimen and adjusting them, because nobody's perfect right off the bat. It's no matter how well you calculate all the ratios and everything, everybody's different. So you're likely going to have to make adjustments. So as long as you adjust correctly, that's the biggest and most important thing, I think, as far as inpatient diabetes control. So how should you make these adjustments? So prandial insulin, the first step is to make sure that the patient actually receives the intended amount of insulin. So if you see that their blood sugars are increasing after meals and you say to yourself, oh, maybe I need to go up on the carb ratio. The first thing you want to make sure is they actually received the correct amount of insulin according to the carb ratio that you already have ordered, because mistakes do happen, or maybe the patient refused the full dose and only would take half of the dose. So that's the first thing before you go changing the orders. And then if you do find that they received the correct amount and they're still increasing throughout the day, that would be the time to consider making the carb ratio more aggressive. And I say that rather than increasing the carb ratio, because when you make the carb ratio more aggressive, you actually decrease the number. So you would go from like a 1 to 15 carb ratio to a 1 to 10 perhaps. And then the correction factor, you can really always adjust based on the total daily dosing of insulin. And then the long acting adjustment. So you'll hear a lot of people say that you want to adjust this until you get morning blood sugars less than 140. And I put 3 stars next to this because I don't love that rule. I think the better goal for long-acting insulin is that you try and keep blood sugars stable overnight. And the reason I say that is because if you have a patient going to bed at 300, a blood sugar of 300, and then they wake up at a blood sugar of 200, that is not a basal insulin problem. That is a prandial insulin problem because they're after dinner, they spiked and their blood sugar went up to 300. So they needed more insulin with their dinner. If you continue to up titrate the basal insulin so that their blood sugar in the morning is less than 140 or less than 180, if you even want to be conservative, then when you correct their mealtime insulin, their prandial insulin doses, and they start going to bed at better numbers, they're going to wake up hypoglycemic. And that's kind of part of why I think we get into trouble with overdosing basal insulin. Really, the whole goal is to keep it stable, not to lower your blood sugars overnight. All right. I'm sorry, I don't know why. Hypoglycemia, so insulin management. So the first step in order to make an adjustment whenever you see even one hypoglycemic event is to try and figure out which insulin was the culprit. And this is where that chart that we went over in the beginning that was not super interesting, but I thought very important is going to come into play. So if you have morning fasting blood sugars that are low, that is most often a basal insulin problem because no other insulin is still acting at 6 a.m. in the morning other than the basal insulin. If you have low blood sugars after meals, perhaps it is too high of a carb ratio, or perhaps the carbs were overcounted or they ate less than they anticipated. So those are other options to think about, but sometimes it is just that the carb ratio needs to be reduced. And then if you have these midday overnight lows and the patient's on NPH, you always want to think about that peak that we talked about. And an important side note is for patients on insulin, once the hypoglycemia is corrected, you still want to give them their scheduled dose of insulin to avoid rebound hyperglycemia. So for example, a patient, you check their blood sugar before lunch, it's 54, you treat it with glucose gel, it comes up to 95 before they eat their lunch. You don't want to let them eat their lunch without their carb ratio, because now their blood sugar is going to get much higher than you want. So it's okay to still give them their carb ratio if you think that that didn't play a role in why they had their low blood sugar. If you think their carb ratio was too high and that's why they had the low blood sugar before lunch, then obviously you should adjust that. But you should still give them some insulin. All right, so transitioning off an insulin drip. So you can calculate this based on several methods. I like to do all three and then compare them to see if they are all lining up. I think it makes me more confident in the doses that I pick if they are all pretty similar. So the first way of doing this is calculating the current drip requirements by adding up the past 24-hour insulin requirements. And this is important to look at if they're eating or not when you do this. So when you calculate or add up all the insulin requirements on the drip, are you calculating a total daily dose? In that case, it would be if they were eating, or are you calculating a total basal dose, which would be the case in patients who are NPO. And then the other question is, are they getting any additional subcutaneous insulin in addition to the insulin drip? So I know Maine Medical Center recommends if a patient is eating on a drip to try and give them a subcutaneous prandial insulin dose on top of it. So that would be something that you would want to calculate into your 24-hour insulin requirements if that is occurring. So that's one way. And then the other way is weight-based, which we previously discussed and went over. And that's based on how insulin resistant you think they are. And then looking at their home insulin regimen, if it's available. The caveat for this way is being cautious that if their kidney function is reduced compared to at home, their PO intake is reduced compared to at home, or their levels of inflammation are different, these are all going to affect their insulin requirements. So if you calculate based on weight or the current drip requirements and they are much higher than their home insulin regimen, but they're actively ischemic, then those would be the things to consider. All right. So again, you want to aim for about 50% long acting or basal insulin and about 50% mealtime Lispro insulin. So this would be a couple of examples of calculating how to transition off an insulin drip. So with adding up the 24-hour insulin requirements. So you have a patient who you've done your math and they've required about 32 units of insulin over the last 24 hours on the insulin drip, but they were NPO. So what you just calculated was the total basal daily dose, which is 32 units. And so again, I do usually a 20% dose reduction to help avoid hypoglycemia. And then their final dose of basal insulin would be glargine 26 units daily. Then again, to look at their total daily dose and get that from the total basal dose, you would multiply it by 2, because again, we try and do about 50% basal, 50% short acting. So if you calculate based on that, you get a total daily dose of 52. And you use our rule of 500 to figure out their carb ratio. 500 divided by 52 gives you about a carb ratio of 1 to 10. And if for some reason you prefer a fixed dose, all you do is divide 26 by 3 for the 3 different meals. And so you would order them for about 9 units of insulin with each meal. And the caveat for that is making sure that they're eating normally and have a good appetite. So the second example would be if you have a patient who is has received about 40 units of insulin on the insulin drip over the last 24 hours, but they are eating normally and they are not getting any subcutaneous injections for their food. So in that case, the 40 units is the total daily dose. And so in this case, you would divide that by 2 to get their total daily basal dose and reduce it by about 20%. So that gives you a basal insulin dose of about 16 units daily. And then you work backwards again the same way, the carb ratio, so if you say, okay, 16 times 2 to get their total daily dose with a dose reduction, you can do 500 divided by 32, and that's about a 1 to 15 gram carb ratio. That was a lot. This is Frog the dog when he was a puppy, the pretty sky in the background. Sorry for all, I think that's all of the formulas that we are doing today. So this should be a little bit easier going forward. Let me quickly look to see if there's any questions. Can you talk more about how you move the time of your glargine dose from morning to night? Your patient usually takes it at night, but is ready after treatment of a DKA episode to eat and receive glargine and prandial at 7 a.m. This is a great question. So once they are on morning insulin or morning basal insulin, and then you say you're getting them ready for discharge and they say, I always take it at night. There's a couple of different options. If you have a few days, you can slowly back up the dose, meaning if it's scheduled every morning at 8 a.m., you can do it one day at 11, then the next day around 2 p.m., the next day around 5, and then send them home and tell them they can take it at 8 p.m. that night. If you don't have several days to make the adjustment, then the better way of doing it is with a dose of NPH. So you take their basal dose, you cut it in about half. That's, depending on, that's a good rule of thumb, but not always perfect. And then you can dose reduce it a little bit if you're worried about that midday peak of NPH, and give them that in the morning instead of their basal insulin. And then you can resume their basal insulin in the evening. Remember, NPH lasts for about 12 hours. So it's a nice way to kind of bridge without any glargine for those 12 hours. All right, it's enough Frog the dog for the moment. All right, another case. So a 59-year-old female with history of type 2 diabetes. At home, she takes glargine 50 units nightly, Lispro anywhere from 4 to 20 units 3 times a day with meals. She comes in with an NSTEMI. She's ordered for glargine 40 units nightly, a Lispro 1 to 10 carb ratio, and a Lispro correction of 1 to 25 with meals. And the plan is for cardiac catheterization tomorrow, and she's going to be NPO at midnight. And so you get a phone call asking what to do with the insulin orders. So when a patient is NPO, you want to be checking the blood sugars every 6 hours. You want to change the insulin orders if you remember, or check the nursing orders just to every 6 hours, not before meals and before bed, because they won't be eating meals. And then for basal insulin, most often for your longer acting insulins, we dose reduce by about 20% as a rule of thumb, sometimes more if you think that they've been getting too much basal insulin at baseline. And for a type 1 diabetic, it's important to remember that you never, ever want to hold all the long-acting insulin. It can cause DKA, even just for short periods like overnight. And if the patient is on NPH, then I usually am more aggressive with how much I reduce the dose, usually by about 50%, to try and avoid so much of a peak when they're NPO, because that really does increase the risk of hypoglycemia. And then the prandial insulin you hold because that's only for meals and they're not eating. And then the correctional insulin you give because that's for high blood sugars. So if they're high, they still need their correctional dose. Great. I'm just checking on the time to make sure. Okay, good. So the next case is a 74-year-old male with a history of type 2 diabetes. At home, he takes metformin and Trulicity. Or delaglutide, excuse me. He comes in with an ischemic stroke. He started on continuous tube feeds after he fails his swallow evaluation. He then becomes altered and pulls out his NG tube just after the glargine is given, of course. And so his current regimen is glargine 24 units nightly, regular insulin 5 units every 6 hours, and then a regular correctional scale of 1 to 25 every 6 hours. So again, when patients are on tube feeds or on TPN, they should be getting blood sugar checks every 6 hours scheduled. Commonly, we try and dose insulin with 50% long-acting insulin and 50% short-acting insulin every 4 to 6 hours, depending on if you're using regular or Lispro. And the reason for this is for this exact circumstance. So if you lose access to your tube feeds, you aren't having all of your insulin as a long-acting, because then you're in trouble. So if the tube feeds are held or stopped, you want to hold the scheduled prandial or short-acting insulin. You can still give the correctional if they're high. You want to dose reduce the long-acting insulin, but it really depends on what their blood sugars are running and how appropriate you think the basal insulin is based on their actual basal insulin requirements off the tube feeds. And so if the insulin has already been given and the tube feeds or TPN is unexpectedly stopped, the blood sugar should be checked more frequently for the duration of the insulin that was just given. So in this case, glargine was just given right before the tube feeds were turned off, and you weren't able to dose reduce it. And so in that case, you would want to check for the next 24 hours before feeling confident that they weren't going to have a low blood sugar. If it was a dose of regular insulin, it would be for 6 hours. And then if the glucose drops to less than 150 or so, you can start a dextrose drip at the rate that the tube feeds were initially infusing as a good starting spot, and then adjust it accordingly. All right, so the next case is a 37-year-old female with history of type 1 diabetes. At home, she takes glargine 26 units nightly, Lispro anywhere from 4 to 16 units 3 times a day with meals, and she comes in with an asthma exacerbation. She started on prednisone 40 milligrams daily. So steroids. So these tend to affect prandial glucose requirements more than basal, and the effect will be based on the duration of action of the steroid. So this is important to know. So prednisone, the effect tends to last about 12 to 16 hours on blood sugars, not the anti-inflammatory, but the hyperglycemic effect. And so it tends to wear off overnight. So these patients have an increased risk for fasting hypoglycemia if you uptitrate all of their insulin. So in these cases, I prefer to really be aggressive with going up on their prandial insulin doses. And I usually leave the basal insulin dose as is, because that really shouldn't be affected as much. And if you're having a tough time, you can always consider NPH during the day, because again, the effect of prednisone on blood sugars lasts about 12 to 16 hours, and NPH magically has a duration of about 12 hours. So it works out really nicely, actually. And then dexamethasone, the effect on blood sugars lasts closer to 24 hours in this circumstance. So you do have to watch out for fasting hyperglycemia can happen. And in this case, if you see that fasting hyperglycemia is occurring, you can also uptitrate the basal insulin in addition to the prandial insulin. But again, I usually start with prandial insulin, and I look to keep the blood sugars stable overnight. All right, so the next case is a 52-year-old male with a history of type 2 diabetes. He takes U500, and he tells you he takes 20 units twice a day at home. He comes in for an infected diabetic foot ulcer, and his blood sugar is 168 when he arrives. And then you order him a diet, and he says he's quite hungry, and he's thinking he's going to be eating well. So U500 insulin worries everybody. So the key is that it's 5 times more concentrated than U100. And so the whole reason we use this is because it allows for administration of higher doses of insulin with a smaller volume of fluid to improve absorption. So if we were to give these doses of U100, it would be such large volumes that it doesn't work as well. And usually we think about prescribing this in the outpatient setting when a patient, or inpatient setting, I should say, when a patient is requiring greater than 200 units of insulin daily. And two biggest things to remember when you have a patient who's on U500 insulin is figuring out the home dose is going to be a little bit trickier. And then remembering that the absorption of NPH, or excuse me, of U500 is closer to NPH than to a rapid acting U100 insulin curve. So again, it's going to look more like this, which allows us to dose it 2 to 3 times a day. And because of this, we are able to use it for both basal and prandial insulin coverage. And we either dose it with breakfast and dinner or with all 3 meals. And then how it's prescribed. So the trouble is, this is where we get the errors. So if the patient is using a U500 insulin pen at home, the amount that they tell you should be accurate. So if they tell you they're on 100 units twice a day, that should be correct because they dial up to the number of units like any other insulin pen. But if they're using a vial and syringe, that is where the errors can occur because a lot of patients draw up U500 insulin with a U100 insulin syringe, which is this orange top. The green top is a U500 insulin syringe. So the markings on this are correct. But if they are drawing up the insulin in a U100 syringe, the markings on the syringe are inaccurate. And so if they drop to a 40 unit mark, they're actually drawing up 200 units of insulin with a U100 syringe. So the question is, how do we figure out what to order patients when they come in with this? So if we are going to keep them on a U500 insulin, the first step is to figure out their correct usual home dose of U500, look at their current blood sugar and see if they're eating similar amounts. Those are more important than patients who are on U100 insulin, because if they are not eating well, we cut back significantly more on the U500 insulin doses than we do with other prandial insulin. So back to the case, you have this patient who tells you they're taking 20 units twice daily of U500 insulin with breakfast and dinner. And then when you do a little digging, you find out that he's actually using U100 insulin syringes and drawing up to the 20 unit mark. And therefore, he's actually taking 100 units of insulin twice daily. And I put this red flag in here because I think it's important to remember is that U500 insulin at a dose of 40 units daily would not make sense because we don't usually prescribe U500 insulin for patients unless they're requiring 200 units of insulin or higher. So if they tell you a number that seems too low, that should kind of be a flag to you to look into it a little bit further. If they say that they're going to eat great, they have a good appetite, I would still reduce their home dose by about 20%. If they're eating, but they tell you not really, they don't feel like they're going to have as much as they usually do, I cut back to 50%. And if they have a poor appetite or they're pretty sick, I reduce it closer to 70 or 80%, because again, in these patients, their prandial component and their effect of the food on their insulin requirements tends to be much greater than with other patients. And I want to give enough time to Cindy to go over things. So I'm just going to go through these slides pretty quickly, and they'll be available as well after the presentation. So the gist of what to do with oral diabetes medications in patients is usually discontinue them and add back once they're stable. And as far as the details of each one, you can read this at a later date. And then just a brief introduction to continuous glucose monitors. I think you're going to see them more often. There's several different types, and the whole point of this is to measure blood sugar based on interstitial fluid, and it does it about every 5 minutes. And then it transmits the data back to a phone or a PDM. And it lags behind finger stick blood sugars by about 15 minutes. It does not deliver insulin or treat diabetes. So I think this is important. And these are a couple of examples of what they may look like. In these cases, even if a patient is wearing these, it's still important to note that they need to be counseled, that we still need to check blood sugars 4 times a day on our machine while they're inpatient due to the rules of Maine Medical Center. All right. And insulin pumps, just briefly. So they are filled with rapid acting insulin. They're most often seen in patients with type 1 diabetes, but can occasionally be seen in patients with type 2. And these actually administer and deliver insulin for treatment of diabetes. And there's multiple different types. They either have tubing, which hooks up to a reservoir that they wear on their belt or around them, or it's all contained within a pod, which would be the Omnipod insulin pump. All right, and just a couple things on insulin pumps. Again, you'll be probably touching base with endocrinology, but it's important to remember that if they have an altered mental status, suicidal ideation, they're inappropriate to be wearing their insulin pump and managing it. They need backup supplies at their bedside, and they should be recording when they bolus for food or high blood sugars. And then if it's ever disconnected or malfunctioning, the rule of thumb is to start an insulin drip immediately and then page endocrinology to discuss an alternative regimen if you're not quite sure what to do. All right, so I'm going to turn over the presentation to Cindy Young to go over a little bit about what the role of the diabetes educator.
Hi, everyone. This is Cindy. I am one of 3 diabetes educators here at Maine Medical Center. And I just wanted to talk a little bit about what we do here in the hospital. The first thing is they've changed our name, so you may see this come across, Certified Diabetes Care and Education Specialist. We can never remember the new title, but that's our new title. Our biggest role is patient education. Certainly, we want to be consulted on any complex cases, complex regimen, non-English speaking patients to help them understand their diabetes management. As far as new diabetes, especially someone requiring insulin or new to testing blood sugar, that's a great reason to consult us. But keep in mind, bedside nurses should be able to teach patients how to drop insulin, and we'll talk at the end of this soon, they'll be able to teach them how to use an insulin pen as well. So if you have any thought in your head that this person might be going home on insulin, they're new to insulin, get the bedside nurses started training the patient right away. It's much better for patient care that they learn and they can practice versus trying to do it as they're going out the door. And I've already talked about non-English speaking. We do a lot of professional education as well. So part of our role is to educate all staff. We develop and maintain a lot of classes, e-learns, we do huddles depending on what's going on. We help with communication to help with education around diabetes within Maine Medical Center. We do a class for all nursing new hires. So anyone new to Maine Medical Center, we go over all the policies in regards to insulin and our approaches here to managing diabetes. We also teach the CNA course, and all of the CNA, it used to be CNAs come through and they can go anywhere, but generally most of them stay here at Maine Medical Center. So we teach them about diabetes. We teach them about how to be a team player, how they can help us to better provide care for people in Maine Medical Center with diabetes. We do provider education. We meet not with everyone, but we do meet with groups of internal med new residents and family med residents as they come into Maine Medical Center. And just really talking about hands-on, this is what you're ordering, this is how you order it. We find a lot of residents have never seen the different syringes or know about insulin pens. And so we do a lot of hands-on, this is what they are, when we have people practice with them. We also do ongoing staff education as identified. So if there's an RL, we see consistent problems on one unit or house-wide, we'll jump in and do education for nursing staff or also other staff as needed. We also look at Maine Med, the inpatient diabetes landscape. So we're on many committees. We work on the multidisciplinary policy procedure development review. So we have a large role in that. We also look at all RLs related to insulin. We look for any, again, as I said earlier, do we see any trends? Do we need to take action? And we we bring that to our glycemic management committee. We do diabetes data tracking, program development from that. We're hoping to get better at that soon, but right now that is a goal, is to get better data for us. And we're certainly patient advocates, so we may be reaching out to providers saying, hey, have you thought of this? Or, oh, you know what, they can't afford their insulin, et cetera. So we're gonna, if trying to send someone home on 4 shots a day who can't even get 1 shot a day, and you'll probably get a call from us to say, let's rethink this plan. And we also belong to Maine Health committees and any initiatives going on throughout the Maine Health system. Often we're involved in those and giving our thoughts around that. So we do a lot here. There's 3 of us at any given moment, patients who have diabetes at Maine Medical Center. It's averaging about 160 per day. So as you can see, we can't see everyone. And so we try to talk about where it's great to call us in areas that might be better served by other team members. So certainly if you want your person with diabetes to understand how to eat healthier, look out to your registered dietitians or your nutrition consult. We can do it, we're okay with it, but that's not our specialty. Dietitians and our dietetics do a much better job, and they have better handouts than we do. If you're looking for management recommendations, of course we can give you guidance, but we're not NPs, we're not endocrinologists. And so our license is not to say this is what you should do with management. We are more likely going to tell you to reach out to the diabetes NPs or endocrinologists. If you're looking for management and not education for your patient, that's really where you want to go. As far as medication supply and affordability, we can kind of guide you, but again, there's a whole care management team, med access team that can really help you. So if you think part of the issue why someone is not managing their diabetes is because they can't afford their supplies, please reach out to your care management team. Ordering diabetes medications and supplies, again, we can help, but the pharmacist can actually look up and see what's covered on the person's prescription plans if they have one. We have created general guidelines and a diabetes after visit instructions and orders. It's an order set that you can use at discharge. We've put the most common diabetes medications and supplies on there, so it's actually makes your life easier, so you don't go insulin out into, I call it the world wide web of Epic, and get 100 choices. You can narrow it down very quickly to, oh, I want glargine. So that order set is being revised to be even more efficient, but also included in that order set, Epic requires you to know how much am I prescribing. So if someone's taking 60 units of insulin a day, you need to know that 1 vial is not going to be a 30-day supply. So we put guidelines in this tool to tell you how much do you need to order, how are things supplied. So it's a great tool. If you haven't seen it, look it up. Usually if the educators are involved, we put in our notes specifically what we've taught them. So if we've taught them vial and syringe and we've gone over it and they can do that, don't discharge them on a pen that they haven't been taught, or vice versa. We tried, maybe nurses tried, we tried to do vial and syringe, they can't see them. We'll put in our notes pretty clearly, please order insulin pens at discharge. And so just check out our notes. It's usually in the bottom if we think they need something specific for discharge. Again, we can help. We can't order anything, so we likely have to look over your shoulder if we're going to help you order anything. So feel free to reach out to us, but pharmacy may be able to help you better with that.
Very much, Cindy. I appreciate it. Unfortunately, I think we have to, it's 9 o'clock. So I did just want to give a couple of minutes for to answer some questions, but your last slide will be available as well when we post the presentation. So it will be available at that point, but I really appreciate your help in going over all of that.
Okay.
Thank you so much. So in summary, we discussed glycemic targets, insulin review, including U500, estimating insulin requirements, how to transition off an insulin drip, some common management situations, and then a little bit about continuous glucose monitors, insulin pumps, and the role of diabetes educators. So I know that some people might end up having to go, but I did just want to address a couple of questions if we had a moment. So one of the questions was comment on evidence for splitting larger doses of glargine up into multiple injections a day. And this is something, you're right, that I don't know I can't cite a good study that has looked at this, but I know essentially it's a problem with volume, and around 60, some people say 70 units of U100 insulin, the volume starts to become an issue. So in that circumstance, you can either split it up into twice a day, or you can use a more concentrated insulin. There's U300 long-acting insulin, there's U200 long-acting insulins, and in that case, it helps with absorption a bit. And then another question that was asked was, there have been a couple of studies describing the use of continuous glucose monitors on hospitalized patients to improve control and limit hypoglycemia. Do you think we could see this practice more commonly in the future, particularly in high risk or high acuity patients? And I definitely think so. And in fact, I was trying to keep an eye on the time, but I do have a study here that addresses this a little bit. So it was published in Diabetes Care in 2020, and that essentially looked at reducing inpatient hypoglycemic events on general floors using continuous glucose monitors. And they looked at about 72 patients who they deemed as high risk for hypoglycemia. And they found that the group that used the CGM had fewer significant hypoglycemic events or hypoglycemic events in general, and then a lower percentage of time spent below that threshold as well. And there was no difference in nocturnal hypoglycemia or time in range or time above range. So I do think that this is something we are going to see more often, and so to be familiar with. But again, it's really more of a tool for the patient to use than it is going to be for providers at this time. We will still be checking blood sugars 4 times throughout the day, or every 6 hours, depending on how it's ordered. So even if they have this on, you don't have to rely on using this data. Are there any other questions? I'm sorry, I kept you guys a little bit over time.
I think that was great. Thank you very much, Rebecca. And I think Steve Hayes, had a question on the CME code, which I can answer, which is 71686. So that's 71686 for those of you that are going to be signing up for CME. So thank you very, very much. It was a great overview. And thank you also to Cindy for joining us as well. It was a great team approach to the presentation. So I guess that'll do it. So we'll see everybody next week. So thank you.
Thank you very much.